now you can read about Charlotte, and of course she's Swedish, I would say. You haven't been living in Sweden for so very long time, but actually you're trained at Karolinska, so that's very nice. You're a neonatologist and you're a professor in pediatrics and in France. You are on a research sabbatical or sabbatical in Qatar at the moment. But you also have been founded the second French NICU training center in Toulouse, in France. And you have been a co-founder of the Green project together with Pierre and others in France. So thank you very, very much for taking your time. And I'm very sorry that you didn't have in person this year with the whole group that you had planned, but please, the floor is yours.
So hello everyone. So this presentation is about implementation of infant family-centered developmental care in a Greenfield single family room level 4 hospital in Qatar. So I have nothing to disclose, and just I wanted to give you a quick update about Qatar. Qatar is in the Middle East, nearly 3 million inhabitants. The migration rate is high. Nearly 100,000 people are moving into Qatar every year. The sex ratio is quite in favor of male. 75% of the people are male because of the high immigration. There are 32,000 live births in Qatar in 7 obstetrics facilities. Home births are very, very rare. The neonatal mortality is 4.28 per 1,000 births. The consanguinity rate is very high in Qatar, 54%, which means that marriage is between first or second degree cousins, and there is 10% prematurity. In Qatar, there are multiple nationalities, as you can see here, many Indians, Nepalis, Bangladesh, and you can see on the right side of the screen that the population of nationals, in fact, is not very high over time. Now, 10% of the population is nationals, and all the rest are expats, in fact. So Sidra Medicine, this is a very big hospital that opened up in January 2018. It's a women's and children's hospital. And what is so innovative in this hospital is that there are only single patient family rooms. You can see how the structure is of this hospital. You can see that there are 3 cells, and that is the entrance for the parents and the families. They go into gardens, and through the gardens they come into the unit, so that they have kind of a nice impression when they come into the hospital. So in this brand new hospital, medical, nursing, allied health staff came across the whole world, and there are more than 63 nationalities working in this hospital, and we are linked to Weill Cornell Medical College in New York. There is a campus in Qatar. NICU is on 2 floors with 2 times 27 cots. So implementing infant family-centered care and developmental care in this hospital, well, you have to address different issues. There's a specific patient population. How are the parental expectations? What about this fantastic architecture of the NICU with only single family rooms, even in the ECMO room? And also, the last but not the least, it is a Greenfield NICU that needs to be built up. So if we look at the specific patient population, we in Sidra, well, if we look at the first 6 months of 2019, well, the gestational age is 36 weeks approximately, and you can see that there are many cardiac and surgical diagnoses. It's a level 4, so there are other NICUs in Qatar, but in Sidra, referral is made for all the complex cases. Death is 7%, prematurity rate is 58% of the patients that come into an ICU. And you can see also that the congenital abnormalities are high, 46%. We are part of the Vermont-Oxford network, so we can compare our data with all the other level 3 or 4 units worldwide that are part of VON. And what I just wanted to show you here is that you can see the green dot is the Sidra unit, and the bar is where the rest of the level 3, 4 worldwide are in terms of gestation, small for gestational age and congenital abnormalities. As you can see, our rates are really much higher. Again, here you can see that for here specifically, that major surgery, where we have high levels of surgical babies if we compare to other level 3 and 4 settings worldwide that are part of VOM. Oh, sorry. So that is the first challenge. The population is complex and very sick with surgical complex abnormalities and also genetic issues. Secondly, what about the parental expectations? So again, we need to know that, well, most of the patients, well, they come from different countries, but as you can see on this chart, most of them come from the Middle East and from Asia, but from various cultural backgrounds and social levels. So we set up quite quickly, when the hospital opened in January 2018, education sessions for parents in an ICU. And we, despite communicating a lot about it, the attendance was rare. So we had a social worker that did an audit by phone to explore the expectations and the motivations of the parents to attend to these sessions. She talked to 34 parents, 20 mothers and 13 fathers, and the barriers that the parents talked about was that they didn't have time to come to the education sessions for 20 of them, but 2 of the parents said they prefer to spend time with the baby instead of coming to the education session, and for 30, so really the vast majority of the parents, they felt that there was no need of education sessions in the unit. And then talking about their expectations, well, most of them, in fact, had non-expectation at all. 10 of them had wanted to have more private face-to-face sessions because they felt they want to talk about their baby and not in general. And 3, quite few of them, wanted to maybe have a session about breastfeeding. So this is raising really, so how did they perceive, how did they felt about their role in an ICU? I think that at this stage, we can see that we haven't been able to communicate in a way that make them feel that they are doing a difference for their baby. Or, well, there is something that is missing, that is clear. The third challenge after the patient's profile and the parents' expectations is the architecture of an ICU. So here, the NICU on 2 levels, 3C and 4C, you can see a view here, and you can see there are only single family rooms all over the unit, very big and really a fantastic environment. Here is the neonatal intensive care advanced integrated room. So this is for the very sick babies and for ECMO babies, and there is still a bed space for a parent. So in this fantastic architecture, how can then this staff coming from 63 different countries in a country they don't know, how is the staff experience of single family rooms in an ICU? We wanted to evaluate the staff perception of single family rooms after 1 year of opening. And we did a web-based survey that we sent to the NICU team. We asked 16 questions to explore their perception about the family's experience, safety of clinical care, and the work environment. And we used a Likert scale to explore the responses. So 5 is very good and 1 is very bad. So here is some demographics. You can see that most of the team is quite young, below 50 years. Many nurses responded to this survey. Mostly it is women, and the experience in a single family room unit previously was rare. 9% of the team had some experience in that. Most of them had good experience in neonatology, and most of us were in Qatar for not a long time, less than 5 years. And here, if we look at the different parameters, you can see here, so on the first column, you can see the different parameters, and then it goes from good assessment to mostly bad assessment. So the communication of parents was felt to be good, family access to the baby was good, but then quality of patient care, it was, well, not significantly different between good and bad. The privacy for families was very good. Family interactions was felt as not very good. The feasibility of skin-to-skin was very good, and noise level as well. But the communication among the staff was felt as not appropriate, and the staff peer support was not good as well. And the ward round experience also was bad. And there was also the feeling that staff couldn't leave the room for breaks. So all the persons that had a bad assessment of different items on the Likert scale, so less than 2 or same as 2, we did a qualitative study about that, and here is kind of the mapping of that, and it's a colleague called Natalie Verhaas that did this nice graph. And you can see here that, in fact, well, these family rooms, the staff felt that there was risk because they felt that the baby could be treated less safely with some inequality because the nurse couldn't hear the baby or had less time for the baby. She had to walk between the different rooms. They felt that the families were more isolated and they could be less supported, and also the staff felt less support when there was an emergency, when they needed support. They felt alone in this room, and also not knowing each other. Again, you have to remember that all of us, we didn't know each other, in fact, very well. So feeling that also the learning opportunities were rare. When the ward round was there, they were only experiencing 1 or 2 rooms and not hearing about the other babies. So the conclusion is that, in fact, these single family rooms in this very particular setting, again, a new hospital with a new team, with a fantastic architecture, well, it is beneficial for the families, but the staff felt it impacted the patient care. There were feelings of isolation and concerns about the safety. So, of course, that doesn't question the importance of family rooms. Just we need to have in mind that adjustment of the organization of care is needed to optimize the benefits. So in Sidra, we have improved awareness of the potential staff isolation as assigned breaks were more regular or more clear for the nurses. Nurse leaders and floaters were available also for the rooms. We also encourage nurses to work on the computers outside the room to meet and share, and psychological support was also put in place. So that was the third part of this challenge. And then, well, the fourth is that, well, this NICU level 4 with ECMO and surgery and, well, is a Greenfield NICU. So we have at least 12 quality improvement projects ongoing in an ICU, everything from avoiding term admissions into neonatal units to small baby group to unplanned extubations. Let's just show you quickly that the unplanned extubation rate was high when we opened, and now it has come down. That breast milk as discharge was not very good and now is increasing. And antibiotic administered within 1 hour after ordering also went up on this run chart over time. But a lot of processes needs to be put in place in various aspects. Of course, an important group is the developmental and infant and family-centered care core group that is working really hard. Hospital beds for mothers in the NICU rooms are encouraged because by now it's regular beds, and when the mother is has newly delivered, well, an hospital bed is more appropriate for her. Training in family-centered developmental care is done. Education sessions for parents. We still try to find a good way to reach the parents, and we feel, in fact, that like Inga Warren said, really it's about parent empowerment, that they feel that they can do a difference. So we are supporting the implementation of a parent association in Qatar. We also plan to do a research study on the skin-to-skin in these very complex babies, and we have been celebrating to raise awareness the World Prematurity Day. So in summary, Sidra is a new hospital with a really unique environment. The workforce comes from different countries, the families with multicultural background, and well, work is in progress. There's a lot of work still to do. Thank you for your attention.
Thank you so much, Charlotte. Thank you. Impressive unit, and I'm stunned. Do you think that actually the single family rooms are so many, 27 per floor? Of
Yes.
course, the meters between the staff and the family rooms must be quite wide. I mean, the distance many times. So it's...
Exactly. There's a lot of walking, but I think also when, well, we need to be aware of that the learning opportunities of the nurses is less if you have a multiple cot environment. Well, the nurses can learn much easier from each other. It is different. So as I think for us, it was really like an experimental, because new team, new setting, and an environment, new country. So everything was there to make things difficult. But I think that, yes, we need to be aware of that. The rooms are fantastic from a certain point of view, but we need really to follow up and help and support so that the staff doesn't feel isolated, and also the parents, because here in this survey we didn't talk to the parents about this. It is only a survey for the team. So of course, next step would be to have the view of the parents.
Yeah. In your setting, are parents always present? Are the babies never left alone?
No. Exactly. So we have for the NICU beds, we can have one nurse for one baby sometimes when the baby is very sick, or one nurse for 2 babies or 3 babies, and so the baby will not be left alone. But then the parents' attendance is not. It is very variable. Some parents are there all the time. Some parents are coming often in the evening or the night more than in the day. It is very variable. And I think that the wardroom is very kind of open, and the parents are part of the wardroom. They know everything we talk about and we discuss with them, and we have translators coming, so it is really kind of translated on the spot. But I feel the parents have more the feeling they come to defend their baby, but they don't really see, or we are not able to show them what they can do that we can't do. that is something we need to work on more.
I don't know if Siri is still in the meeting, but I remember she points out that when you have family rooms, it's extremely important that you have a good communication between the staff, so that you write down what you have discussed, so that if a new person enters the family room, it should be easy to get an idea where they are, what has happened. And she also showed me charts we sometimes use for how far the parents have developed in their competencies, and they are sometimes openly displayed in the room. So when you enter the room, you can see, oh, these parents, they think they know this, but they need help with this. So you need to find out different methods of increasing communication.
Yes. Yes, it is a challenge. I think it was really striking for me when I came to Sidra that it is really a challenge that, the handling and the way of working must be adapted to that architecture.
Okay.